bit of biochemistry. So this topic is going to be a little bit vast because this physiology biochemistry is not a lonely topic. It will have overlapping with general pathology. It will have overlap with general medicine. A little bit of oral medicine also will be overlapped in this physiology topic. And some amount of pharmacology knowledge also you should be knowing when you're studying general medicine. So the pure physiology part and a bit of biochemistry part I'll be dealing in today's webinar, and the continuation of the remaining parts wherever it has overlap with other subject, we'll have separate webinars on subsequent days when we are dealing with pharmacology, general medicine and general part. So moving on to the today's webinar. So I have divided the physiology into different systems, and under each system the only must know topics which are very important for the exam point of view, only those alone I'm going to discuss it. In case if you are planning to skip this topic, physiology and biochemistry, just go through this webinar and the points related to this webinar alone, if you cover, it is more than enough. So first system is gastrointestinal system, gastrointestinal tract and liver. So under that you have organs including starting from the esophagus till the liver and the surrounding structures of the liver will be covering. So first one, the important one related to the gastric system is the type of gastric cells and the substances secreted from them. So you have mucous neck cell which secretes mucus, and the mucus will provide a protective lining to the stomach, as well as it stops acid regurgitation. Then it also produces bicarbonate which helps in neutralizing the acid. Next one, parietal cells, they secrete gastric acid, hydrochloric acid and also intrinsic factor. So intrinsic factor, the extrinsic factor is calcium, intrinsic factor is secreted by the parietal cell. It will help in absorption of calcium. Then you have enterochromaffin like cell which secretes histamine, and this histamine will stimulate the secretion of acid. Then we have chief cells. Chief cells secrete pepsinogen and gastric lipase. Then we have D cell which secretes somatostatin, and this helps in inhibiting the acid. Then we have G cell which secretes gastrin. This stimulates the acid. So D cell and G cell, they have opposite effect. So now, knowing the types of gastric cells and the substance secreted, the next important point is what are the parts of the stomach and where all the cells are concentrated. Like some parts will have some amount of cells in more in numbers, some part will have other group of cells more in number. So it is very simple. As soon as the esophagus ends, you have a small part of gland called as cardiac gland. Then you have the stomach slightly goes upward and then downward, and then it curves to join the small intestine. So that when it curves, that the C-shaped curve is called as cardiac gland. Then it goes up. The upper part is called as fundus, and the larger great part is called as body or corpus of the gland. Then we have pyloric antrum and canal. So now, after knowing the parts, the parts of the stomach are very important to know the concentration of different groups of glands which have varieties of gastric cells. So these are the cells which are present in different types of gland, and each particular group of gland will have the concentration of cell, the distribution of cells will be different. For example, the cardiac glands mainly has this group of cell which is the mucous neck cell. It is very simple and it is understood from the concept. Cardiac gland is at the entrance of the stomach. So you should have more amount of mucus lining and the bicarbonate cells in the cardiac gland, so that there is no acid regurgitation, because acid is the pH is very strong. So if there is not enough protection, it will erode away the esophagus. So for that reason, the cardiac gland has a very protective lining of more number of concentrated mucus cells, which provides complete protection to avoid any acid regurgitation back into the esophagus. Then starts the fundus and body of the gland. So these part of the stomach will have mainly oxyntic glands. So oxyntic glands are also called as principal gland, or other name is fundic gland. So this will have the major amount of all the other types of cell, including the chief cell, parietal cells will be mainly concentrated in this fundus and body. So they will have all the major action of the stomach will take place in this complete oxyntic group of glands. Then lastly, towards the end of the stomach, you have the pyloric part, which has pyloric gland. So pyloric gland, slowly the parietal cell, chief cell will vanish away completely, and it will have more amount of G cell and D cell. So G cell and D cell, they will have inhibiting and stimulating action of the acid. So it will basically neutralize the acid into a stable pH, leading into finally it leads the food content into the intestine. So it is a closure of the stomach. So you will not have a major acid secretion activity, rather it will just have stimulating inhibiting effect neutralized based upon the amount of secretion of the acid in the stomach. So this is the main important point from the GIT from physiology point of view. Apart from this, you don't need to study anything from GIT. Next is liver. So liver, mainly from liver, what you should know is the bile, bile salts, bile pigments. First, you should know what is a bile. Okay, bile is a liquid which is prepared in liver and it is stored in gallbladder. So this bile will help in digestion, it will help in absorption of fat, and it will also help in excretion because it emulsifies and solubilizes the fat, and so it helps in excretion. So now this bile liquid contains what all? It contains bile salt, it contains phospholipids, and it contains small amount of cholesterol and bile pigments. So remember, bile pigment is a composition of bile. So bile is a liquid which contains both bile salts as well as bile pigments. Now comes the confusion. Bile as a whole, it is made in liver. But when you split up the composition, bile majorly comprises of this bile salts, but it also has a small percentage of what I mentioned, bile pigment. This particular bile pigment alone is exclusively formed from when a hemoglobin is degraded from the heme, these bile pigments are formed. So this is a difference between a bile salt and bile pigment. So bile salt, it is completely manufactured in the liver, whereas bile pigment, which is a very small component of the entire bile liquid, this bile pigment is formed from heme. When a hemoglobin breakdowns, the byproduct of the heme is bile. So bile pigments include bilirubin, biliverdin, whereas bile salts include cholic acid and chenodeoxycholic acid. Now bile salts, majorly it will get reabsorbed by the ileum, whereas bile pigments will be completely eliminated with feces and urine. Now the biochemical analysis of bile, just the name alone, these two names, if you remember, it is more than enough. So for checking the presence or increase of the bile, you will be using Foucher test and Hay test for analysis of bile. The next one important is related to jaundice. Even if you don't understand the complete concept behind jaundice, just remember jaundice is something related to this bile pigments which I mentioned. So when there is increased concentration of serum bilirubin, it is called as jaundice. So this jaundice can be caused because of various reasons. So which part of the organ the bilirubin mechanism is getting altered, depending upon where it happens, you can divide the jaundice into prehepatic, hepatic or obstructive jaundice. So as I have already mentioned, the bile is stored in the gallbladder. It is formed in the liver, and the bile pigments, they are derived from the blood. That is the degradation of the hemoglobin. So with this concept in mind, you have to first know prehepatic. So prehepatic means the bile pigment, as I mentioned, bile pigment, though it is derived from hemoglobin, it has to go to the liver, it should get conjugated, and then only it goes to the gallbladder, gets concentrated in the gallbladder, and after that it is secreted into urine. So this is the root of a bile pigment. Now, before entering the liver itself, that is called as a prehepatic stage. So the bile pigment has not entered the liver itself, because before that itself there is some problem. So what is the problem? When there is excess amount of hemolysis, the RBC, it should have a normal duration for a hemolysis. So before that itself, if it is the hemolysis occurs at a very faster rate, because there is more hemolysis, more amount of bilirubin is being produced. So when there is more amount of bilirubin, it will not have enough time to go to the liver for conjugation. So which means when the serum bilirubin is increased and when you test for the serum bilirubin, it mainly consists of unconjugated hemoglobin. Then if the problem is at the liver, that is hepatocellular jaundice. So if the problem is at the liver, you will have some amount of unconjugated, some amount of conjugated bilirubin. Whereas there is another group of jaundice called as obstructive jaundice, which means there is no problem at the hemolysis level. So the bilirubin is normally formed. There is no problem with the blood. So the normally formed bilirubin goes to the liver. Liver is also having no problem. So it undergoes normal conjugation. But after that, when it gets stored in the gallbladder, there is some issue in the gallbladder. There is some issue in the bile duct. So it does not get excreted properly. So because of that, there is some obstruction. So such bilirubin, when you check the serum, it is mainly a conjugated bilirubin. So that is the difference between three groups of jaundices. Prehepatic, mainly there is a RBC issue. There is large amount of hemolysis. So serum, you will have mainly unconjugated bilirubin. Excuse me. Is my voice audible? Is the screen visible? Okay. Is the screen visible? Okay. So let's resume back. Jaundice, we have prehepatic, hepatocellular and obstructive jaundice. Serum, it will have unconjugated bilirubin in case of prehepatic, unconjugated plus conjugated in hepatocellular, whereas only conjugated in case of an obstructive. And the reason for prehepatic, it is mainly hemolytic anemia. Hepatocellular jaundice is because of some liver issue, mainly because of hepatitis. Usually it is a viral hepatitis, whereas if it is an obstructive jaundice, it is mainly because of any stone in the gallbladder. After that, you don't need to study anything from GIT and liver. So liver, mainly jaundice is important. For GIT, the parts of the stomach glands and the cells and the, what all the product the each and every cell secretes. These are the things which you should study from GIT and liver. Next system, the respiratory system. Nothing much from respiratory system from physiology point of view. So physiology, this point is very, very important. Inspiration and expiration. The main muscle of inspiration is external intercostalis muscle, whereas for expiration it is internal intercostalis muscle. So to remember, for I it is E and for E it is I. So it is just opposite. So for inspiration it is external intercostalis and the diaphragm will be there in both the sides. Accessory muscle for inspiration is sternocleidomastoid and for accessory muscle for expiration is abdominal muscles. The next one from respiratory system is Herring-Brewer reflex. So Herring-Brewer reflex is a reflex which happens when you take inspiration. If you inspire, you can do it yourself. So take a deep breath. What will happen when you're doing an inspiration, when you're taking a deep breath, your muscles will stretch completely. So after your muscle stretches at one point, without your consciousness itself, you will go into expiration. The reason for that is when you're doing inspiration, the muscles of inspiration get stretched. At one point, when it stretches more, the stretch reflex itself will give a negative feedback asking you to contract. So it will lead to expiration. So this reflex is called as Herring-Brewer reflex. That is, it will have an inhibitory reflex on inspiration. So when you are doing inspiration, the stretch receptors will get activated, which will cause expiration. This is called as Herring-Brewer reflex. Next point is oxygen dissociation curve. This is from biochemistry point of view from respiratory system. It is very important MCQ. So oxygen dissociation curve is nothing but when there is acceptance of oxygen by the hemoglobin. That is, the hemoglobin takes oxygen. It is called the shift is towards the left. When the oxygen goes out of the hemoglobin, the shift is towards the right. Even if you don't understand the concept, just remember, if the curve shifts to left, it means it is hemoglobin is taking oxygen, which is called as oxygen affinity. If the oxygen goes out of hemoglobin, it is called as shift to right. Now, what all condition will lead to left shift? What all condition will lead to right shift? So, for left shift, it is called as increased affinity for oxygen. So it happens when there is reduced partial pressure of carbon dioxide, reduced hydrogen ion concentration, which means increased pH. Remember, hydrogen ion concentration is related to acid pH. So which means more amount of hydrogen ion concentration, it means more acidic, which means reduced pH. So if they say reduced hydrogen ion concentration, it means reduced acid content, which means increased pH. So reduced partial pressure of carbon dioxide, reduced hydrogen ion concentration or increased pH, reduced 2,3-diphosphonate glycerol, and increased temperature. These all will lead to a left shift. Apart from that, HPF. HPF means fetal hemoglobin. Always remember, compared to an adult hemoglobin, a fetal hemoglobin will have more affinity for oxygen, which means the curve will shift towards left. And for right shift, it is a straight opposite. What all features you studied for left shift, it is a complete opposite for the right shift. So this is a very important MCQ related to biochemistry from respiratory system. Even if you don't study anything from respiratory system, just this one point if you study the right shift, left shift, oxygen dissociation curve, it is more than enough from biochemistry. It's a very important question. Next, moving on to the renal system. So under renal system, nothing much from physiology point of view. This one particular feature you should know. Something called as a loop of Henle and vasa recta. So you have something called as counter current multiplier and counter current exchanger. Even if you don't understand the concept, just remember, loop of Henle is called as counter current multiplier and vasa recta is called as counter current exchanger. So here what happens is, the fluid in the loop of Henle, you have a descending loop and an ascending loop. So descending loop, it will flow in one direction, and in ascending loop, it will flow in opposite direction. So when it flows in one direction, in the descending loop, what happens? The sodium will come out and water will get reabsorbed. Whereas in the ascending loop, when it goes up, the sodium will get reabsorbed, whereas water will go out. So whatever goes out and goes in, the substances which goes out, it will get absorbed with the vasa recta. So that is what is called as vasa recta is called as counter current exchanger, because whatever substance the loop of Henle releases out, it is getting exchanged by the vasa recta, and whatever is getting reabsorbed, the vasa recta secretes something and it is being absorbed by loop of Henle. So just remember, counter current multiplier is loop of Henle and counter current exchanger is vasa recta. No need to break your head to understand the concept, but just these words will help you out during your last minute preparation. Now, tubular reabsorption of glucose. So there are two words, very important words, that is tubular maximum and renal threshold. So tubular maximum for glucose is 375 milligram per minute, which means when the load increases more than 375 milligram, the glucose will appear in urine. So that tubular maximum is 375, whereas there is something called as renal threshold, which means in the plasma, when particular amount of glucose level increases, the glucose will appear in urine. So the renal threshold for glucose is just 180 milligram. So don't get confused. Again, I'll tell you, 375 is the tubular threshold for glucose, which means in the urine tubules, if the glucose content increases more than 375, it will not function. It will appear in glucose, which means it will appear in urine, which means the urine tubules does not have capacity to reabsorb glucose when the content is more than 375. But it will not lead to that situation at all, because when the plasma concentration of the glucose itself increases beyond 180, it will not reabsorb more. So when this threshold itself is reached in the plasma, it will appear in urine. So don't get confused between these two words. Just remember, tubular maximum means it is 375, whereas the renal threshold for glucose is 180 to 200 milligram per deciliter. Next one, the major segment of nephron and their function. Even if you don't understand a lot related to this table is very, very important. But at least the most important point from this table is the proximal convoluted tubule, distal convoluted tubule, and the collecting duct. So proximal convoluted tubule and the distal convoluted tubule and ascending limb, in both the three things, if you see, there is reabsorption of sodium, whereas the descending limb of the Henle's lobe, there is reabsorption of water, which means the sodium, it does not get reabsorbed, whereas sodium gets secreted in the descending lobe. So again, I'll repeat, the major amount of reabsorption takes place in the proximal convoluted tubule. A little bit of reabsorption takes place in the ascending limb and the distal convoluted tubule, whereas in the descending limb, there is reabsorption of water and there is little bit of secretion of sodium. Next, moving on to endocrinal system. So endocrinal system, it is very important. There are many glands. These glands and all, you should know the functions of each gland and what are the substances secreted by each gland. So if you ask me from physiology, which system is very, very important, endocrinal system is important. Each and every gland, at least the hormone it secretes, and the basic function of each hormone, if you read, it is more than enough, of which the parathyroid and the calcium homeostasis from the endocrinology is very, very important for us. So pituitary gland, I'm just running through. Anterior pituitary, you have some hormones, and posterior pituitary, you have some hormones. Just the name of them, if you know, it is more than enough. So from anterior pituitary, you have ACTH, TSH, LH, FSH, prolactin growth hormone, and melanocyte stimulating hormone. And then posterior pituitary, you have antidiuretic hormone and oxytocin. Just the name is more than enough. Then you have adrenal gland. Adrenal gland, it mainly has two parts, adrenal cortex and medulla. So adrenal cortex has three layers. It is very important. So you have zona glomerulosa, then zona fasciculata, zona reticularis. Glomerulosa secretes mineralocorticoids, which includes aldosterone. Zona fasciculata has secretes glucocorticoids, which includes cortisol and corticosterone. Then zona reticularis, which is innermost, it secretes androgen, which contains all the testosterone. Adrenal medulla, which is in the inner portion of the adrenal gland, it secretes adrenaline, noradrenaline, and dopamine. And you have something called as hypothalamo-pituitary axis, which is the hypothalamus will secrete corticotropin releasing hormone into the anterior pituitary, and anterior pituitary in return will secrete ACTH, that is adrenocorticotropic hormone, and this will in turn stimulate the adrenal cortex to to secrete the cortisol, and this axis is called as hypothalamo-pituitary axis. Next one is calcium homeostasis, which is very, very important. You should know the action of calcitonin, parathormone, and the calcium. So what happens between these three? So parathormone is secreted by parathyroid gland, whereas calcitonin is secreted by the C cells or parafollicular cells from the thyroid gland. So these two will have opposite action. The calcium, the serum calcium level is meticulously maintained by these two hormones, that is the parathormone and the calcitonin. So you have to read about the functions of them. I've explained n number of times about this earlier. So please go through them and study about the calcium homeostasis. It is very, very important. So the calcium homeostasis, when there is blood calcium level decrease, you have hypocalcemia, and the manifestation of hypocalcemia, patient will have tetany, trosiosign, Schwostek sign. These are the important features for hypocalcemia. So a patient will have tetany. This tetany is different from tetanus. Tetanus is a bacterial infection, whereas tetany is decreased blood calcium level, that is hypocalcemia. It is called as tetany. So these are the important brush up features from the physiology biochemistry. The remaining left out system, here and there it has overlap with general medicine. So when we are taking general medicine and pharmacology, I'll be covering the other systems like cardiovascular system, CNS and hematology. Hematology is a very, very important topic. That will be covered under oral medicine because there are a lot of oral manifestation and it is very important from oral medicine point of view. So when we are covering oral medicine, we'll cover the hematology, and when we are covering general medicine, we'll try to cover the cardiovascular system because that has a lot of features like infective endocarditis and IE prophylaxis. So that time we'll cover, and the CNS and ANS will cover it when we are doing pharmacology. So we are done with today's session. Thank you all.